I'm Elena Marks, and I want to welcome you to our webinar today presented by Laura Pence, who's going to talk to us about updates from NASDOH on the national landscape relating to NMDOH policies. NASDOH is a national coalition. It represents multi-sector partners working to advance the widespread adoption of effective policies and programs to address health-related social needs, as well as the underlying social and economic conditions in which people live. Often called SDOH, but of course we in Texas call it NMDOH. The consortium is a member of NASDOH, and we participate because that's a way for us to learn about what's going on in other states and to share what's going on in Texas and get a better understanding of what's going on from a federal perspective. We're always looking for evidence and ideas to inform what's possible here in Texas. And so we're really happy that you've joined us today to learn about what's going on in the rest of the country. And to tell us more, I'm going to turn it over to our consortium director, Dr. Charles Mathias. Charles, take it away.
Thank you, Elena. I'm grateful that you've joined us here today for this session. This session with NASDOH is timely because we recently completed a policy generation workshop series to gather your insights that will inform a report that we're preparing on policy options for Texas to consider in supporting the health of Texans through NMDOH initiatives. These options are being developed considering the tools and resources we gather from our participation in NASDOH, and this report will be shared with you once it's published in September. For today's session, there will be time after the presentation for to answer your questions. So as questions arise, please post them in the chat, which we'll be monitoring. This meeting will be recorded and shared on our YouTube channel after the event, and we'll email you a copy of today's slides for your reference. Our presentation today is delivered by Laura Pence, who has a wealth of experience in federal policy on non-medical drivers. She is a director at Levitt Partners, which provides expert advice on health policy and value-based healthcare. Prior to her work with Levitt Partners and NASDOH, she was a senior advisor for the U.S. Department of Health and Human Services and previously served as a health policy advisor in the U.S. Senate Committee on Health, Education, Labor, and Pensions. Please join me in welcoming Laura Pence.
Thanks, Charles. I really appreciate that introduction, and looking forward to everyone's questions. And I'm seeing everyone kind of post where they are in the chat. And I think I highlight maybe a couple of your organizations in my presentation. So obviously you will have much better things to say regarding the work that your organizations are doing on NMDOH. But I wanted to provide a landscape of the federal policy. So I'll just start off by saying I'm going to use the term SDOH because that's what I'm used to. It's not because I have a thing about SDOH versus NMDOH or anything like that. It's just what I'm used to. So bear with me on that, please. So I'm just going to start off with a little bit of background on NASDOH, but Elena did a great job. So we're a multi-sector stakeholder coalition. It was actually started in 2018 by former Secretary of Health and Human Services, Mike Levitt, and former Assistant Secretary for Health during the Obama administration, Dr. Karen DeSalvo, who is now, she's now at Google, and actually Google is a member of NASDOH as well. But we're focused on policies related to SDOH, whether that's regulatory, reimbursement, funding opportunities, and we, across kind of all different payers, all different providers. We are mostly focused on health-related social needs. Our background is mostly in healthcare, so we mostly engage with the Department of Health and Human Services, but we have engaged with HUD and housing, with USDA on issues related to nutrition and things like that as well. So just to give you an overview of some of our members, as I said, it's a multi-sector stakeholder coalition. So we have insurers from Kaiser Permanente is a member, ACAP and ACHP are plan associations, including some of their members are plans in Texas. We have community health centers. Mercy Care is a community health center. And we have patient and provider groups as well. So our goal is really to hear from, the variety of different stakeholders that are focused on SDOH and think about, how we can have shared learnings across different states and sectors and stakeholders, as well as how we can work together to advance SDOH policy and SDOH practice in the private sector as well. So moving on to federal policy, this is just going to be a kind of a high-level overview. One thing that NASDOH did a couple of years ago was look at the last 5 years, what's happened in SDOH policy, and think about what our goals are for the next 5 years. So my timeline here goes back to 2018 because that's when NASDOH started, but you can really see these are kind of the biggest, or what we think are some of the biggest policies in SDOH happening over the past 5 to 6 years. You can see, we've included the first 1115 waiver related to SDOH was North Carolina, approved in 2018. Supplemental benefits for Medicare Advantage started around that time. CMMI models, including the AHC model, started, and then moving into kind of 2021, 22, during the current Biden administration, we've seen more kind of cross agency and cross department plans and implementation for how to embed SDOH across different healthcare programs. Many more 1115 waivers have been approved. Additional guidance for Medicaid has been put out. And I think one of the biggest things that I think you are all familiar with is the White House playbook on SDOH that came out in December of 2023. So a lot of the work this year and potentially in a second term would be implementation of that playbook and the goals and activities that are listed in there. I'll go into more detail in some of those things. So this is broken down by kind of different payers and different providers. So Medicare, we've really seen things happen in the previous administration and in the current administration. So as I mentioned, Medicare supplemental benefits was something that happened, CMS started providing different flexibilities, and then Congress came in with the Chronic Care Act and provided Medicare Advantage supplemental benefits, which over the past 5 years, we've really seen explode in popularity. Very important for Texas, as nearly half of all people in Medicare are on a Medicare Advantage plan and have these supplemental benefits available to them. And actually in 2024, we've seen maybe a little bit more of a interest in how these supplemental benefits are being used, whether they're being used, and some transparency going into place to make sure that people who have these supplemental benefits available to them know that and are reminded kind of during the year that they can utilize these services. As I mentioned, the North Carolina 1115 waiver approved in 2018. There have been, I have a slide later about the number of waivers that have been approved since then. And then right actually at the end, the very, very beginning of 2021, it was January 21, CMS put out a guidance on Medicaid and what Medicaid can cover within SDOH. And that guidance has been updated by the current administration as well. So there's been a number of resources put out for states to utilize 1115 waivers and other Medicaid flexibilities as well, which I will go into a little bit more. CMMI, I do have a slide later that kind of highlights the Texas participants in the AHC model, but that one has concluded, but kind of one of the most direct ways for testing out payment for SDOH infrastructure. So not just kind of the health related social needs services or connecting and referring people to care, but also providing for the infrastructure needs to kind of build that out more. So as I mentioned, we've started seeing some new guardrails being put on supplemental benefits, and I think we'll continue to see that in the next few years. But they have, tended to be very popular among Medicare Advantage plans to offer these services. One thing that Congress has started looking at is kind of the prior authorization and kind of who's using these supplemental benefits and when they're using them, how they are actually available. And so that's been of great interest, but this is an area that has really exploded over the past 5 years, and opened up a lot of opportunities for seniors to access services for health-related social needs. Recently, this was in the past Medicare fee schedule for, how doctors are paid. A pretty big step forward is they added a new payment option for doctors that are providing a risk assessment within the annual wellness visit. So as providers are taking care of Medicare patients in their annual wellness visit, they can do an SDOH risk assessment and get paid for doing that risk assessment. They're also providing payments separately for kind of auxiliary personnel to help providers with community health integration, with SDOH risk assessment, and principal illness navigation services. A lot of this work is done by community health workers, which is an area we've also seen a lot of interest from states and from the federal government in kind of advancing the role of community health workers. Another area that has really started kind of exploding in the past several years related to SDOH is quality measures. This is something that NASDOH has spent quite a bit of time on because it's very, there are a number of different quality programs and a number of different quality measures. So it can be kind of hard to, understand who is responsible for doing the screenings, but most of these quality measures are related to doing the screenings and, assessing does somebody have, issues with transportation? Are they experiencing housing insecurity? Have they experienced interpersonal violence? And food insecurity is another health-related social need that is, largely being screened for. So it is required in the hospital inpatient quality program. So essentially this means that all hospitals that are getting paid by Medicare, which is all of them, have to do this screening. And this is implemented already. So this has been in the past couple of years that this has been really required for hospitals to do. And so, when you require something, intake goes up a lot. And I think, we're even hearing anecdotally from kind of the community that there's been an increase in referrals from healthcare providers to social services because of these quality measures and having to screen. They aren't required right now to refer. So that's, something that NASDOH is very interested in, is making sure we're not only screening people and saying, okay, thanks for letting us know that you have housing insecurity, but what are we going to do with that information? And actually making sure people have access to the services that can address that issue now. It's also been included in the Medicare-based incentive payment system, which is for providers across Medicare. HEDIS, which covers health insurance plans, private health insurance plans. So this is Marketplace. This is also Medicaid, MCOs. They are required to report on a social needs screening and intervention measure. So this one, they are required to refer for the services once you identify that somebody has, a food insecurity or housing insecurity or something like that. And then kind of in these additional smaller payment programs or kind of alternative, more innovative payment programs, we are seeing that some of these measures are being adopted in there as well. So this is, kind of maybe a backdoor way of getting a lot more screening happening in the healthcare sector. One thing that NASDOH is also interested in is, how, if somebody goes from a doctor's office and they need a surgery, so then 2 weeks later they're scheduled and get a surgery, are they being screened for their health-related social needs within 2 weeks and what happens after that. And so making sure this is all really patient-centered, and we're not just screening for screening's sake, which can be helpful in understanding kind of what a person's if they are released from a hospital after their surgery, are they going to be able to refrigerate their medicine if they need that? Or, are they going to have nutritious food to kind of support their recovery? Those are also important, but, I think the end goal is, of course, addressing those needs for patients. Let's see the next slide. So this one, as I mentioned, goes over the 1115 waivers. I didn't go into all of them, but of course, North Carolina was the first one. And then this chart at the bottom, you can see so far 10 states, or as of April, 10 states have waivers that support the infrastructure funding or delivery system changes. So this can be funding for supporting data, supporting kind of the exchange of data, utilizing a Unite Us or a Find Help service. It can also be the workforce needs, or just kind of generally the staffing needs of doing the backbone organization work for kind of connecting the social service providers with the healthcare providers. And 18 have housing supports, so this is a very common one. Nutrition supports, employment supports, and medical respite are additional. These waivers really, spread the gamut, right? Some you have everything kind of from our home, which is in Arkansas, and they're focused on kind of populations that have substance use disorder and mental health needs, and focusing on housing supports for that population. And then, everything to kind of like CalAIM, which in California is their waiver. They've got a lot more going on with NSDOH, but, I think some of the states that are maybe more relevant or similar to Texas are, their 1115 waivers are really focused on specific populations that are of high need. So potentially people that are, experiencing homelessness or at risk of homelessness, and have a lot of healthcare needs, focusing on health-related social needs for those high-risk populations and populations that potentially may cost more in emergency department funding or costs. But 1115 waivers are not the only thing that states can use. And I think in lieu of services is the other flexibility that many states have used, and I think could be of interest for Texas. So this is something that CMS has put out a lot of guidance on recently and made some changes in regulation to make this more flexible for states. So in lieu of services is, very much what it sounds like. In lieu of, having to pay for an emergency department visit, we're going to offer some sort of preventive service. So, a lot of states are using this in the mental health and substance use disorder population to offer like inpatient or intensive outpatient care, or housing supports for people with mental health and substance use disorder needs. And this is something that states can do without having to go through the entire waiver process. And it is just much more straightforward. It doesn't open up the existing 1115 waiver. I know Texas is not wanting to be opened up anytime soon, and kind of go through the political rigmarole of an 1115 waiver and the DSRIP and all of the supplemental payments that can go into that. But in lieu of services is kind of separate from that process. And is a way for states to provide, and CMS has kind of opened up the opportunities and flexibility, and has provided some guidance for states on how to do that. So that's an area of interest. One other thing that kind of beyond the Medicare items that we've talked about previously, CMMI is the Center for Innovation at CMS, and they've provided a number of models, some of them related to SDOH. But actually, in recent years, they've decided that any of the new models going forward are going to be required to screen for health-related social needs. And they have kind of this overarching goal of advancing health equity through their work in CMMI. And so there are entities in Texas that participate in CMMI models, and so are, incorporating some of these changes that, that don't have to go through kind of the state Medicaid agency or focus on kind of what, it's just direct interaction with the federal government and kind of what their focus is. As I mentioned earlier, the accountable health community models is one of the original ones that really focused on screening, providing services, and also supporting the backbone organizations to make all of this work possible. I think on the next slide, I have these are the entities in Texas that have participated in that model. That is, sorry, the ACO REACH model is a separate one, but a number of states have participated, a number of Texas entities have participated in that one. And then, there was another model related to Medicare Advantage and kind of similar to the supplemental benefits. And then I here have the ACO REACH model, which focused on enhancing care delivery and coordination for underserved patients. Each entity had to develop a health equity plan and target underserved communities, and then implement initiatives to address health disparities. So, I think even, there is a lot going on in Texas within the Medicare fee-for-service space, Medicare Advantage space, and the CMMI space. That kind of come directly from the federal government. This is a tool that NASDOH put together just to kind of understand what CMMI is focused on, all of their different models, kind of what components of SDOH. So we didn't look at every single model that CMMI has done, but we've looked at the recent ones that are, that CMMI generally says like, hey, we've focused on SDOH, or we've focused on health equity in this model. And I think, you can see most of the models that are in that space are working on screening and addressing social needs. So this is the housing, the nutrition, they're less focused on kind of the underlying drivers, the social determinants. And, we haven't really seen any of the models besides the AHC model focus on kind of supporting those backbone organizations. So that's another area of interest for NASDOH's work, is thinking through, what are the opportunities for the infrastructure supports to make kind of this underlying SDOH and some of these health-related social needs more feasible across different payers and more embedded into, the payment system in general. I briefly discussed in lieu of services. So actually Texas does an annual report on the current in lieu of services. They have some in lieu of services right now that are related to mental health and substance use disorder, and focus, and it was interesting, I think in the report in 23, they noticed that they were interested in thinking about ILOS as part of their overall health-related social needs strategy. So, I think indicating this is maybe a potential area of interest. A couple other things that are actually, ongoing in Texas. So CDC, this was in the current administration, started offering funding for states, locals, territories to do an SDOH acceleration plan. There are 3 recipients in Texas that received this SDOH funding from CDC. I couldn't find who the 3 are. Maybe you're on this call, I don't know. But, so there is, grantees from CDC, and then there's a similar program in that's a combination of 2 different agencies at HHS that's focused on kind of this community care hub model and supporting kind of that infrastructure. And there are 4 different entities in Texas that I saw that have received funding and are receiving technical assistance. And I think I saw somebody hop on the call earlier when you were putting all of your names and names and entities in the chat. I think I saw somebody from the Houston Health Department join. So they are one of the entities, and would be interesting to hear more about that. One of the things that we've seen from the current administration is a lot more kind of cross-agency, cross-department work on kind of embedding social needs and so SDOH into healthcare. This is something that I think, you know, if there is a second term of the current administration, we would see a lot of implementation on some of these activities. And if, you know, not making any statements on who I think will win or who I think should win. But, you know, this is an area where I think, you know, we've seen a lot of progress in the past 5 years between the, you know, current and previous administration on SDOH. But I think this is what we would see more of a focus on if there was a second Biden term. As I mentioned, I think you're all familiar with the White House SDOH playbook. The focus on expanding data gathering and sharing, supporting flexible needs or flexible funding, and then supporting backbone organizations. You know, I have here, which is way too much information to actually go over, but, you know, all of kind of the goals of each one of those actions. It's a ton of items. There's no way it's going to be done today, this year. There's no way it would be done even, you know, in another 4 years. But these are, if you're wanting to know kind of what a second term would do, this is a pretty good outline for where their interests are and where their focus would be. So looking ahead, just a little bit more into like maybe what we're going to see over the next 5 years. Obviously, I don't think anyone is surprised, it is an election year. There are so many different opportunities for what the political makeup could look like. I think this is pretty obvious, but we just have, you know, them depicted here, 8. And really, you know, some of these are definitely more likely than others. But it's really hard to predict what's going to happen in the next 4 years, given at this point, you know, there's still so many possibilities for what the landscape could look like. You know, a couple of the things that I think we are confident in, we are seeing a number of members of Congress that have really focused on healthcare and are kind of in healthcare leadership positions retiring. Some of those in Texas, some of those, you know, the rest all over the country. And so I think we are going to see a lot of newer people kind of stepping into these healthcare leadership positions. And, you know, there's, you know, for NASDOH's work, we have a lot of kind of education on SDOH and NMDOH to do in Congress, given kind of that some of these kind of long-term champions are retiring. And, you know, I think in terms of kind of what we could see with a different makeup, you know, I think Medicare Advantage supplemental benefits is kind of a bipartisan interest at this point. And, you know, making sure that people who have them available, you know, understand them. One thing that the Senate Finance Committee is starting to look at is, you know, the people who are not in Medicare Advantage don't have access to these supplemental benefits. And so, you know, are there ways for Medicare fee-for-service or kind of CMMI models or kind of to offer more value-based services in the Medicare fee-for-service rather than just the Medicare Advantage? And I think, you know, you guys in Texas are very familiar with kind of the importance of the terminology and the language. We actually experienced that very much too at the federal level. Not everyone at the federal level is okay or, you know, positive about the term SDOH. And so, you know, it's in our name, so we're kind of stuck with using it. But when I go and talk with certain members, I definitely kind of avoid using that term. And I think, you know, in a more Republican, either kind of Congress or administration, things like talking about value-based care is, I think, one way that that Republicans think about this a little bit more. And, that's one way to kind of help kind of bridge the gap between, we all have this goal of reducing the cost of healthcare by addressing people's, needs that are impacting their ability to be healthy. So thinking about, are there innovations in the private sector, and are there, things that we can kind of frame in a value-driven or value-based way that are really kind of getting at the same goals that we all have. And I think, regarding 1115 waivers, I think, mentioned the first one was in 2018. So there may be a little bit of a difference in kind of what a different administration would approve in 1115 waivers, but I still think that we would see additional states being able to kind of adopt SDOH innovations in the 1115 waivers in ILS, or in different flexibilities, particularly, as they're related to kind of high needs and potentially high cost population. So if we're looking at people experiencing homelessness, or veterans, or people with mental health and substance use disorder needs, those generally tend to be more bipartisan in thinking through how to reduce healthcare costs and address the health related social needs of those populations. So I will stop there and open it up to questions. I'll just note several of the things that I talked about are in NASDOH's Social Determinants of Health Federal Policy Landscape Look Back and Ahead. I didn't go over kind of NASDOH's goals for the next 5 years, but if you're interested, our website, it has that resource on there, and thinking through, really a lot of our goals really focused on how do we embed a lot of these changes, as opposed to, being a demonstration model, or opposed to being a pilot program or kind of temporary funding here. How do we really embed these learnings into the healthcare system in a more sustainable, long-term way? So that's a lot of what NASDOH is focused on. And then we do have a newsletter that we send out monthly, and it provides, not only what NASDOH has been up to, but federal policy updates, and then what our members have been up to. So we do share, I'm sure you all hear directly from Texas NMDOH Consortium on what they're doing. But we do like to include their updates and then the updates of our other members as well. And then any questions, feel free to reach out to me. My email is there. Would love to hear from all of you guys. I am actually a Texan, born and raised in Texas, and I'm living in Austin. So have been in DC for 12 years, but recently moved back to Austin. So really excited to be back in Texas, and I'll open it up to questions. Thank
you, Laura. That's a great overview for us. We're so fortunate to have NASDOH kind of leading these efforts and helping us inform us here in Texas with this federal landscape, and lucky to have you here in the state. I'll open it up to questions in just a moment. I have folks come on their mic. I'll just note a couple that I had grabbed so far. Laura, you mentioned that the NMDOH policies have really been advanced in both Republican and Democrat administrations. How do we keep it bipartisan or nonpartisan and prevent it from really getting sideways with the politics of this?
Yeah. As I mentioned, I think y'all are very familiar with this, but the terminology is really important. That's kind of why I apologize for calling it SDOH at the very beginning, because that's what I'm so used to calling it internally. But I know that term is not really okay with everyone, and that's true at the federal level too. So I think thinking about it in a value-based care transformation, really driving towards lowering healthcare costs for the reason why NASDOH was started was because Governor Leavitt and Karen DeSalvo were working together actually on the response to Hurricane Katrina. and really seeing like, okay, even if we get our hospitals back up, and even if we get people doctor's appointments and get them to the doctor, their health is not going to be, they're not going to be healthy. They're not going to be where they could be, and so there's a lot more that goes into being healthy than just kind of the medical system. And so, I think that is a very bipartisan premise, and really thinking about the terminology and what we use. And I think there's also specific health related social needs that are probably a little bit more bipartisan too, like thinking through transportation. That's generally kind of been a long-term thing in Medicare. Thinking through nutrition, I think that's also a very bipartisan thing, whether it's food as medicine or, just it's very understandable that like if you don't have access to healthy foods, you are not going to be healthy. And, housing really, with Medicare supplemental benefits, I think a lot of people have kind of understood, if you don't have, if you don't have utilities and you can't refrigerate your medicine, that is a very, that is going to impact your health and potentially, may result in you having to go back to the hospital, going back to the emergency department. And, obviously that being a much more expensive way to address the problem than, having your utilities covered. So I think, talking through some of those examples without any sort of terminology associated with it is one way to kind of, get past the potential partisan issues. And then, also just thinking about, how do we make our healthcare system work better for patients? I think is, just one, another way to frame it. Republicans are going to generally more think about it kind of as value-based care. Democrats might, generally use terms like health disparities and health equity a little bit more than Republicans. But there is really a lot of bipartisan agreement on kind of the underlying issues and, working on addressing it.
Great, thank you. I've got a couple other questions noted here, but I'll go ahead and see if anybody wants to raise your hand or unmute yourself to ask Laura any questions you developed during this presentation. Well, go ahead.
I've
Elena.
got one.
You got more than one, Elena.
Yeah, I've got tons of them. But if somebody wants to go ahead of me, I can always find Laura. So Laura, if you were us in Texas and you were looking forward to the next legislative session, knowing what you know at the federal level and being a Texan, where would you say we are most likely to have success, and what are things that are least likely to be successful in terms of legislative strategies?
I think, probably a more successful way to approach it is to kind of focus on specific populations. So, I know that there's been work on the pregnant and postpartum women population and kind of addressing needs there. And even, the continuous coverage and continuous eligibility for women 1 year postpartum was something that the Texas legislature passed. I know that there was some drama there, but, it did get passed. And so, also mental health and substance use disorder population, that is a very bipartisan issue. I think people are very used to thinking about peer supports, prevention, recovery, it being a process for this population. And so I think thinking about health related social needs for that population as well, for the homeless, for the for veterans, I think all of those populations are just generally, people are very bipartisan issue topics. And so thinking through, okay, it's probably not all of what we want to get to, but if we just start with some different populations, expand it out, from there, we may have more success than just trying to go with, the entire Medicaid population or the entire, XYZ population. And of course, it's also helpful that, when you're doing it like incrementally like that, it's a little less expensive. But, also thinking through just the number of opportunities that there is with the federal government too. So whether it's a CMMI model, participating in that, or, applying for any of the grant funding that's going on. I think those are ways that you can kind of get these, the funding and the transformation in Texas, that's not necessarily just specific to what the state legislature will do.
Thank you. Anybody else want to unmute yourself or raise your hand to ask a question? I love the slide that you had, Laura, of that showed like since 2017 or 2018, the different kind of federal activity on this. But can you tell the audience like just a feel for like the momentum of this work? Like, are we accelerating? Are we slowing down? Like, what's the across time? Do you feel like it's just constant growth, or is it kind of starts and one step back, two steps forward?
Yeah, I think we've seen exponential growth, starting from kind of the very end, like it started with CMMI and Medicare Advantage. And so things that were a little bit more like, all right, here's where there's already flexibility. And we're already kind of testing new things. So let's also just test this one other new thing. Where, we're starting to see it more in the physician fee schedule and payment systems, in the quality measures, it's starting to get itself embedded. And I think a lot of those things, regardless of what happens over the next 4 years, the payment for the SDOH risk assessment, I don't think that's going to go away. You have to do an entire rulemaking process to undo that. And I just don't think that there's enough, there's not enough people that would say, wow, we really don't want to pay for this, that are gonna kind of go and undo that and then undo the progress that's been made for providers, as providers are already getting used to that. Similar quality measures can, be retired and be, added. I don't think, but that is a very slow process. There's kind of the advisory bodies that have to go through that, and then CMS looks at it, and then it gets adopted. And so, some of these things have already been adopted, and then some of it is like, okay, it's like starting in 27 or starting in 25, these things are going to be adopted. And so there's a lot of those things that are happening kind of in the rulemaking process there. It takes a lot to change, and they're just not, while they're really impactful and kind of embedding SDOH in there, they're not the kind of high level political concern. And then I think, if we see a change in administration, with 1115 waivers, we may see more like focus on the specific health related social needs, as opposed to kind of the more infrastructure funding that's not tied to a specific recipient. But I don't think that impacts really what Texas would want to do. And, I think we, in iOS too, I think, that is, I'm not sure that the flexibilities would really be rolled back there, because it just wouldn't be as high of a priority for a second term, for, especially kind of not at the beginning of a new term or second term. There's so many other kind of higher level political things that somebody would want to get to before they're like, okay, yes, let's change the guidance on iOS to really roll back something. So I really think, a lot of these things that have been embedded, all of the kind of cross-sector plans, I think those are relevant to the current administration. A new administration, I think, some of those things may be embedded, because obviously the HHS has worked on these things. And there are, thousands and thousands of staff at HHS that still stay there and continue to work on their projects. but it, would just be a little bit more of a behind the scenes process as opposed to seeing a new, a splashy plan come out. It would just be kind of behind the scenes.
That's a valuable perspective because we don't, see that in our news headlines, and it's just overlooked. I think just the amount of kind of procedural guidance, rulemaking that kind of support make this work possible. I do see a hand up. Artist Laurel, do you want to unmute yourself and ask your question?
Sure. Hi, Laura. Thanks. I'm Laura. I'm Ardas Laurel. And I worked for state Medicaid for 15 years, and now I actually work as a contractor with the Dell Medical School, specific to Medicaid policy. And I have a very technical question, so I'm a little reluctant to ask it, but I'm just going to go ahead and go for it. Because, with value-based care and alternative payment models, unless something is actually a benefit in Texas Medicaid, managed care organizations can't get credit for it. So when they go through their community rating process to kind of determine what their rates are going to be, if they have done a successful APM, technically, they may not necessarily get credit for that the way that the capitation experience is calculated. And I hope I have that technically accurate. But do you know of another state or states that have actually figured, because every states do different, their capitation processes differently, right? Do you have a sense of another state that has sort of cracked that nut where you can have more opportunities specific to alternative payment models with what we call in Texas non-medical drivers of health?
Very technical question. I don't know the answer to that. I think state health and value strategies, they have a lot of resources that are related to HRSN and kind of Medicaid programs. That's the first place I would go to look. But that is a really interesting question, and I apologize, I don't have the answer to that one.
I just barely have figured out how to even ask the question. So thank you. Sorry if I put you on the spot. It's just something that
Yeah.
I keep bringing this up, hoping that there's some. I've heard actually Arizona might have a way they've done this, but I haven't gotten a chance to research that yet. So
I think it is. Your point is really well taken, though. I think one of the things that NASDOH has been working on is shared learnings across Medicaid programs and across states. Just thinking through, like right now, there's definitely guidance out there on 1115 waivers and ILOS, but some of it is like, okay, you just kind of have to see if CMS will approve it or not. And there's definitely pros and cons of like, okay, do you want a list of what we'll actually approve and how states will actually, how states have actually done this, because then maybe it's limiting. But we've asked CMS, and this is actually in some legislation, to do some learning collaboratives for states that are kind of facilitated by CMS, to think through what has the state done, what has the state done, and provide these learnings across states, because I think your point is well made of like, we just don't always know what other states have done, and or even what kind of barriers they went through, how they overcame those barriers to get that policy done. And so I think we're very interested in having learning collaboratives for that very reason.
Thank you, Artist. Great question.
thank you.
I also see a raised hand from Rhonda Aubrey. Rhonda, do you want to unmute?
Hi, yeah, thank you. Hi, Laura. I'm Rhonda Aubrey. I'm at Del Med. I'm curious if you hear conversations coming out of other agencies that are more directly tied to the drivers that we're talking about. So HUD or USDA, is there recognition that the services they're connected to generate health? And so some of their policies are reflecting that, maybe making it easier at the state level to kind of blend services together for solutions that address the non-medical drivers of health. Just curious about that.
I think the two, Department of Ag, which does like SNAP and WIC, and then HUD, which of course does housing. I think those we have seen, NASDOH had somebody from USDA come and who was very interested in this topic, and we've seen kind of the White House like nutrition forums, and they've brought together USDA and HHS, and so I think in some areas we definitely have, housing and nutrition being more, but it really has a lot to do with the people that I think are there. And it being a particular interest and passion of theirs, and the leadership of bringing together different departments, because we all want kind of SNAP and WIC and Medicaid to be a little more aligned and work together and be easier. But even in Congress, like they're dealt with by different committees. So there's experts in Congress on SNAP and WIC, and then there's experts on healthcare, and very few people know, across those issues and how to kind of streamline those. So I think there's a lot of barriers to making that happen, and it really just depends on kind of the people, and being brought together to do that. And I think one thing that USDA has done recently is that they've had like a healthcare kind of advisory group. So, people that may not be their normal constituent group, have access to those people, to come and talk about like what all of that, what all the impacts are, what all of it means. And I think that is, just incredibly important for them to kind of hear from the stakeholders that your constituents may be farmers, and but they really are the patients too.
Great, thank you.
Yeah, I think on that topic, it makes me think there's more challenges, I think, than folks assume about just coordination of activities amongst the different federal agencies. I think we saw really great coordination among HHS in general, and then SAMHSA and HRSA on some of the opioid things, and they use a lot of the similar language and approaches, and that was like a good example of coordination. But once we start moving beyond a health agency into agriculture or housing or even transportation, it gets harder and harder to kind of speak the same language and get those organizations kind of facing in the same direction.
One thing I failed to talk about was community health centers. Those are incredibly bipartisan. I mean, every member of Congress is like, how can we support community health centers more? All the time, that's their goal. And so, and they do a lot of this work. And, so highlighting innovations that are being done, and kind of how community health centers can do more with additional supports and additional resources, whether that's in Medicaid, whether it's, pilot funding, if that's where we need to start. I think that's also an incredibly bipartisan area, and there's community health centers all over, and so a way to really get access, provide access to patients to these services.
Great, Laura, thank you for that. I'm watching the clock, and we're almost out of time, so we probably have time for one more pressing question. If anybody has a last comment. Okay, seeing no hands raised, or I'm going to go ahead and wrap us up. Thank you, Laura, for your presentation, and thanks to our audience for participating on this webinar and in the discussion section. Before we sign off, I always want to alert you to the consortium's program index. This is our catalog of programs across Texas that are sponsored by health system organizations like plans, providers, and hospital systems. The index is a single repository for NMDOH programs that feature abstracts of the programs with searchable fields, including sponsorship, the drivers of health, target populations, health conditions, locations, and evaluation status. Our goal with the index is as a resource for everyone to be aware of what's happening within the state. And this index will only be as robust as you help us make it. So I'd like to invite you to contribute to this effort by connecting with Jackie to add an abstract to the NMDOH program index that you are implementing. The link to the program index is in the chat, and please check on this link and bookmark it for when you can add information. Our next learning session will be held July 9th on the Pathways Community Hub, a model for connecting patients to NMDOH services, presented by Elizabeth Lutz from the Bexar County Health Collaborative. So check our events page at driversofhealthtx.org. Thank you for today's conversation. We're grateful for your input. We really want your feedback about this webinar. You'll receive a short survey from us in the next several days. This consortium is going to be what we make of it. So we need to know what's working for you and how we can help deliver that to you. Please stay in touch with us. You can always reach out to our consortium manager. Jackie is reachable at jk90@rice.edu. Thank you again and have a great day.